So the second talk I'm going to give is about my role on citizens' juries in Jersey and more recently in England. And I'm thinking really about the role of public policy participation in shaping policy on assisted dying. So along with another legal academic, Professor Suzanne Ost from Lancaster University, we were legal advisors to the Jersey Citizens Jury in 2020. Well, it was actually 2021. And then 2 years later, in 2023, I co-authored the ethical review of the Jersey law proposals. Then last year, Suzanne and I reprised our roles, but in a slightly different way, when we both supported the Nuffield Citizens Jury, which was the first English citizens jury on assisted dying. So this is a form of public engagement and public participation, with the idea being that it's really important to find out what ordinary people think about contentious issues. And this can be done in a variety of ways. Snapshot and a sort of superficial overview about what people might think. Referendums are often used as well. So, for example, in the Republic of Ireland, when they were deciding whether or not to make abortion laws more liberal and relaxed to give women better access to abortion, they had a referendum. And this was obviously informed by public campaigns and stuff on the media. And then a more intense way, involving obviously far fewer people, but a much more in-depth exercise, is to have citizens' juries. So on the issue of assisted dying, approximately 70% of the British population believe that assisted dying should be lawful in certain situations. And this is a kind of long-standing phenomenon. So you know, over the past couple of decades, since I started following this, opinion polls routinely say that somewhere between 65 and 80% of the public believe that assisted dying should be lawful. So the most recent, or one of the most recent ones, was done in the autumn of 2024 by the Nuffield Council on Bioethics, who were the organisation who arranged the citizens' jury. They found that approximately 70% of the British population think assisted dying should be lawful. But people often disparage the importance of opinion polls, and they question whether people really understand enough about an issue to be able to, you know, provide a meaningful sense of what the public and the general public believe about something. On assisted dying, there's evidence that actually there is quite a lot of confusion about what it means, and there is confusion. Again, this was a study done by Nuffield last year. There's quite a lot of confusion with assisted dying and palliative care, for example. And people who are opposed to assisted dying have often argued that if people really understood it and the implications of it, they probably wouldn't support it. So there's good reason, it's argued, not to take on board these opinion polls, because they come from a place of misunderstanding what it means, or not really understanding the full implications of lawful assisted dying. So one way to improve understanding is to get a group of lay people together and educate them about a particular issue, and then ask them what they think. And so that's exactly what was done, first of all, in Jersey. So the series of events in Jersey is that campaigners for assisted dying organised an e-petition, which many people signed, and then they presented it to the then health minister in Jersey. And they then committed to hold a citizens' jury and also to follow the decision that the jury made about whether or not assisted dying should be lawful in Jersey. And the question that the jurors were asked was whether assisted dying should be permitted in Jersey and if so, under what circumstances. So they selected the jury by a process known as sortition, where they send out information to a large group of people, and then from volunteers, they sort potential jurors to be reflective of the population in terms of gender, age, ethnicity, and also in terms of what their view about the particular issue is. So the jurors that were selected were representative of Jersey views on assisted dying, which meant that the majority to begin the process were in favour of assisted dying. And so there were 23 jurors in the Jersey process. And they sat through many, many hours of evidence over, I think it was 3 months, in which they had 3-hour meetings where particular issues were covered. So, for example, in one of the meetings, we heard evidence from jurisdictions where assisted dying is lawful. In another meeting, they heard evidence from doctors, palliative care doctors, and doctors who were either opposed or in favour of lawful assisted dying. And the evidence was very balanced to make sure that they got a very objective sense of the evidence that wasn't skewed either in favour or against allowing assisted dying. At the end of that process, the jurors voted on whether assisted dying should be permitted in Jersey, and 3/4 of the jury voted in favour of allowing both medically assisted suicide and euthanasia for terminally ill people and for those suffering unbearably. So this was quite a liberal approach, following the sort of model of lawful assisted dying that we see in countries like the Netherlands, Canada and Belgium, rather than the more restrictive approach that we've talked about earlier in the Leadbeater bill. So the original proposal in Jersey was to have 2 routes. The first was for people who were terminally ill and expected to die in 6 months, or if they had a neurological condition such as motor neurone disease, then they would be given, it would be open for people who might be given approximately 12 months to live. And then the second route was for adults suffering unbearably, but not from a terminal condition. And this route would need court approval, so prospective legal authorization. Then, following the ethical review of the Jersey law in 2023, there was a vote in the Jersey Parliament, which is their state's assembly. They voted in favour of accepting Route 1 for terminally ill people, but they voted against allowing it for people who are not terminally ill. And so the Jersey plans are now being developed on that basis. So more recently, I was then invited to be involved in the Nuffield Council of Bioethics English Citizens Jury, which was convened about a year ago in spring 2024. The question that the jury were asked to consider was, should the law in England, and by England actually they mean England and Wales potentially, be changed to permit assisted dying? And that's obviously because when we talk about English law, we mean law that applies in England and Wales, but not Scotland, because they have a separate legal system, and potentially in Northern Ireland, although that gets quite complicated, and I won't go into the kind of constitutional traditions of all that. But effectively, the jury sat during spring and early summer of last year, and just like the Jersey jury, they heard hours and hours of very balanced evidence across a range of issues. And then in June 2024, they voted on the results, and 2/3 of the jurors were in favour of permitting medically assisted suicide and euthanasia for terminally ill people. Interestingly, they didn't confine the eligibility in the jury exercise to adults. and they suggested that we should be open to allowing people who are not yet aged 18 to access assisted dying in the event of terminal illness. There were 30 jurors involved in this process, and in the final vote, because some people were ill, I think there were 28 present. So the English citizens jury were also asked to give a sense of what their main concerns are to inform the debate. And they identified them as empathy, compassion for people who might be suffering and dying, and also making sure that the ethics of any lawful assisted dying are carefully considered. They were also very concerned about protecting vulnerable people who might be put at risk in the event that assisted dying is lawful. Thirdly, they were very keen that any approach should respect the autonomy and self-governance of individuals. And they also highlighted the need for a national conversation to feed into developments about assisted dying. Also, not present on this slide, they were very concerned to make sure that palliative care was improved, and they saw palliative care as crucially important within the debate, because if there isn't good enough palliative care, people who otherwise wouldn't want to die early might feel compelled because it's the only option for a good death. So this is my final slide. Reflecting on both exercises and the value of this kind of lay democratic participation, both juries debunked the myth that if people understand more about assisted dying, they're far more likely to oppose it. A small minority of both jurors did change their minds from the beginning of the process, but we saw this happening in both directions. So, for example, a very small number of people who said they weren't sure or they were opposed to assisted dying changed their mind and became more supportive, whilst similarly, change happened in the other direction as well. So understanding more about assisted dying didn't generally change jurors' views, but it did enable them to engage with the nuances of the debate. And the extent to which both these juries have contributed to the debates about whether assisted dying should become lawful in Jersey and in England and Wales has been quite variable. So obviously in Jersey there was a firm commitment by the Jersey government to respect the views of the jurors, whilst in England this exercise was done by a very important organisation who are obviously not part of the state in terms of the Nuffield Bioethics Council's role, and they are hoping that the exercise and the work that the juries did will inform debate on this very important issue. And that's it for me for now. Thank you.
Well, again, I get some very interesting points about the role of getting ordinary citizens involved in such a complicated issue, and probably discovering they understand this more than many people would otherwise think they do. Well, thank you again. So, without further ado, let's go on to good Lord, sorry, Nancy. Yes, sorry, and off we go.
Thank you. Thanks for inviting me. So really what I'm going to talk about is what can we learn from what happens in practice from other jurisdictions. So a lot of the debate is ethical, hypothetical. This is kind of trying to learn from people who've been involved in an assisted death, what it was like for them, whether they're a healthcare professional or a bereaved family member. Just on this slide, it's to kind of show the growth in assisted dying legislation. And you know, for a long time, it really was Oregon, Switzerland, and the Benelux countries. And then it started to grow, and it's grown, and it's grown, and it's grown. And so I think we can see now that more and more jurisdictions have brought this in, and this is causing challenges. It's also causing a big question about how should we implement this. And at the moment, a lot of the debate is not very focused on the how. And hopefully you'll hear some of the issues in the how from what we've learned from other countries. So the first thing we did was some research with healthcare professionals who were caring for people who were undergoing an assisted death. Now, some of them may be involved just in their general care, and others were directly involved in assisting the death. So in the Netherlands, we interviewed people from hospices and also staff from care homes. In a lot of countries, assisted dying happens in the home. It doesn't happen in hospitals. But the Belgium, Netherlands may be a bit different, and Canada, but the vast majority of places, really, this is something that happens in the home. So when we interviewed this doctor, they said to us, I can discuss with the patient, with the team, and agree it's the best option, but to take away the life in a moment and inject the medication, that's something else. I'm still not ready for it. So the ideas of conscientious objection are a little bit more nuanced. So people may understand it, may agree with it, but they don't want to be involved as a healthcare professional. Another person said, I had a colleague who was all for it, and I can't do it anymore. Because even if you're in favour of it, it becomes a burden when you do it 3 or 4 times. It's stressful to kill somebody. And we often don't think about the people involved on this side of the debate who would actually be enacting a change in the law. The big thing that came across was this was never a normal death. Now think about care homes and hospices. Dying is pretty normal. But for them, these deaths were not normal. It's a little bit strange that someone is going to die tomorrow at 7 o'clock. It's very strange. They talked about these as a death that stayed with you. They could talk about a room that whenever they went in it, they remembered the person who had died. There's a quote here from a doctor who talks about when there was an assisted death, it's really important to arrange support for yourself. They talk about going out and having a drink so you've got something to do in the evening. Some people will say take the rest of the afternoon off. Can you imagine that in the NHS? They talked about some people being able to do that for 6 cases a year, and they said, well, I just couldn't imagine doing that. I can manage 1 or 2 a year, and it takes me that long to get over it. So these were often the people who are really caring for people day to day, unlike perhaps in Canada, where you have the MAID teams who might go around as a service, which is potentially where the UK is going, who are volunteering to take on this role, or in Switzerland, where they have Right to Die association doctors or volunteer doctors taking this on. It was very much seen as part of care, but there was a recognition about optimising palliative care resolve many of the requests. And I think one of the concerns with the bill for us is that there's no obligation that you would speak to someone with a palliative care background, because it's not just that they could help manage your symptoms and manage your death. They can also debunk and hopefully reduce the fears you have. You may have seen a bad death, but that might not be the death you're going to have. And most doctors are really poor at having these conversations. Palliative care doctors, palliative care nurses, these are very used to these conversations and can have them with compassion and help people understand what they might be facing. But in the Netherlands, they saw this as a continuum of care. So this person said euthanasia is something that is part of a treatment trajectory you go through together as a patient and as a physician. It feels wrong if patients can go to a clinic getting their euthanasia as a sort of product. It shouldn't be like that. In Washington State, which is a bit like Oregon, similar laws, we interviewed staff who had gone through or helped people with an assisted death. As this person says, who is a medical social worker, I find the intersection between death with dignity and hospice really interesting. But the reality is most people that are doing it are on hospice, but it's uncharted territory for our culture. A lot of the hospices will not allow patients to either have an assisted death in their building or even allow the staff to talk about it, which, as this medical social worker said, it's really difficult because I can't talk to the patients. And the cost of the medications is very high in the US, and we think that's partly because the pharmaceutical companies don't want to be associated with it. There's also issues in trying to find a pharmacist to dispense the drugs because they don't want to be complicit in the act either. And we looked at how people really saw this as whether this was suicide. We've talked about suicide a lot today, and right on the far extreme of suicide was gunshots and intentional overdose. Whereas things like use of sedation or withdrawal of treatment or voluntary stopping eating and drinking were seen much, much more as a natural death. If there's no discussion, it can really cause problems. So here was someone said he had a fear of getting into pain, so I'm not sure if he trusted us in hospice that we could mitigate the pain if he got into it. He shot himself in the head. He left a suicide note and apologised to his family for leaving a mess. We never saw it coming. There was no depression notable leading to his suicide. And the number of staff who had walked in and found someone after a gunshot injury or has helped a family was really quite shocking. In Switzerland, palliative care doctors we interviewed, there really is a big role here for institutional conscientious objection. We often think about the individual doctor, but whole hospitals have opted out. They rarely allow it in the hospital. A few that do allow their staff to perform it, but most, if they do allow it, they will bring in Right to Die Association doctors to perform the act. But pretty much most people are opting out of it. Again, happens in the home. The law there is very vague. It's just saying that you can assist someone to die, and doctors have some guidelines, but they talked about being a legal vacuum. But they actually quite liked that because it made it easier to refuse to be involved. In fact, none of the palliative care doctors we spoke to did prescribe or did even do assessments, and they really tried to stop the conversation about assisted dying, telling them that there was palliative care options. As one person said, though, it is the responsibility of the palliative care professionals to hear and explore the implicit or explicit requests for euthanasia and address the suffering underlying these requests. So they're taking a palliative care approach, they're not taking an assisted dying approach. So we almost saw a continuum of involvement from that I can't be involved and literally will not discuss it, or I'll discuss it but nothing else. I'll assess but I can't prescribe. I can do 1 or 2 a year, or for some people they felt okay. Part of the bill that Alex was talking about, the need to find another doctor, that's really challenging. There's a huge secrecy in this and a taboo. Anyone in palliative care who does get involved often doesn't admit to it because they're fearful how it will go down for their career. They're not sure how it'll be viewed by others. Research with bereaved family members revealed that there was sort of 5 phases to making the decision for the assisted death, and this came out of our interviews in Switzerland. So there was this contemplation where the patient really ruminated on this on their own. Then they feel that they want to get someone to help them and gain acceptance, and they share it with 1 or 2 key people. Again, there is secrecy. This is not widely shared. This is something really quite difficult, and you don't want to have to explain this to 20 people. The next part was getting permission from the healthcare worker, and this is when it became really difficult to navigate, try to find someone who was actually going to help you do the assessments, to help you get the prescription and go through the whole process. And then there was organising it, and this is where the Right to Die associations came in, which is quite a unique feature of Switzerland, where they pretty much have taken this out of healthcare. And then there was the aftermath, which I'll talk about, where the bereavement, because of the secrecy, could cause problems. But a big element was to respect their wishes, even if you don't agree. That's how family members who supported felt. So the process for the families, he left good. He left as he wanted, surrounded as he wanted. So the bereavement has gone fine. And overall, our research has shown pretty positive elements on bereavement. But as this other person said, the violence is there too, a different violence compared to a natural death or a classic suicide. It's there, but it's spread over the people. We also interviewed British families who'd been to predominantly Dignitas to gain an assisted death. And again, this isolation that came about because of the secrecy when you're helping someone was really paramount. So whilst they were helping them, they had a lot of anxiety about the illegality of the act. And they also felt they had to suspend their feelings. This was all about the patient and not them. There was also this sort of stigma of suicide, which was quite difficult to deal with. However, after the death, they felt this real element of campaigning, that they could lessen their anxiety now because the act had happened. They could start to open up and challenge the stigma of suicide and felt power in joining with others. But I thought just some quotes just so you could understand what it's like going through the death. So this was just before the death, and this was a British family. So everything about it was just heightened. Every moment becomes really precious. It's impossible to believe that this living person in front of me is going to be dead in a few hours. Just impossible. That evening was very hard because we had a meal together, her last dinner. Neither of us was very hungry, but we had a glass of wine. She joked that it was her last supper. And it's quite amazing what people talked about, this unnaturalness of this, knowing what was going to happen. Then we talk about the dying, and Alex talked about how long this can happen. In Switzerland, they're pretty much now putting up a drip and the person opens the drip. But in this case, they had orally swallowed the medication. So this family member said, the worst bit for me was she started being sick because it tastes very, very bitter. But then she said, I feel woozy, and we got her on the bed. We tried to lie her down, but they said, keep her upright for a bit so the drugs can go through her body. Then she lay down, went into a deep sleep, and after 20 minutes, the physician said she's gone. It just happened very quickly, and she just left. It was peaceful, but it stayed with me. Now, if you compare that death to, say, Oregon, with a different concoction of drugs, these deaths can take an hour, 3 hours, sometimes 6 hours, and sometimes fail. So there's a real issue about what drugs are we using and what drugs would we use if this was implemented. Then there's something about the aftermath, and this quote sort of sums it up. That was tough because I had to deal with the emotional responses for all these people I didn't really know very well. People had known my mother had been very ill, and some people wrote to say that they felt her choice was quite understandable. Others seemed very shocked and disappointed, and that they had not known about her pain before she died. And there's this real feeling that it's left to the family member to manage the expectations of the family. Sometimes those discussions were pre the death, or whether there were fallouts with family members who didn't agree, but often it came after the death where that person was then acting on their behalf. So the concerns going forward, so are we going to find enough clinicians who are willing to do it? Are we going to find enough institutions who are willing to allow this to happen? There's a real fear of healthcare professionals about being involved, may lead to attack, which has been expressed in Australia. Fear that if they're supportive, it will go against their career, and even pharmacology companies and pharmacists having concerns. How do you also support those involved? So we need support for the staff who are involved, and in Australia they have a care coordinator for the assisted dying, but there needs to be real support for the patients and the family both during and after the death, and that has got to include the people who were unaware this was an assisted death and it may have impacted them differently. At the moment, the NHS is in crisis, and there's leaks coming out that if this is to be legalised, this will not happen in the NHS. So some sort of service, and a bit like how abortion is taking place, is predominantly outside of the NHS, may well be what happens. It may be that they go the Swiss route, where there's a big role for right to die associations. But at the moment, the practical elements of introducing this bill are incredibly challenging.
Once again, another collection of quite interesting issues, which again I hadn't the remotest idea of in terms of the complexity. Another layer of complexity, and one on the face it seems at the beginning when I was first started looking at this as a simple choice that an individual might have, and its implications are enormous. It's interesting you mentioned about the idea that doctors may have an option to opt out, which is perfectly reasonable. I'm just wondering what criteria in those countries that have these systems of panels of volunteer doctors, what criteria do they have for choosing them? I mean, I know it may sound rather like some sort of bizarre TV film, but one wonders about the sort of person that might volunteer to want to get into a job killing people. And you might want to weed those people out of that. And I was quite surprised again that in Switzerland, with the image, it's almost like a free-for-all. Anybody turning up, I want to go. That there are whole hospitals that opt out of this system. So again, another layer of complexity there. Right, so we have quite a bit of time here for any questions. But for a start, I'd just like to ask any members of the panel here whether there's any comments they want to add or to raise their own questions to the other two members from what they've heard in their presentations.
Just on the with my ethicist hat, and I think that last point about how you choose doctors who are willing to. You're right. There's kind of something intuitively a bit queasy making about someone who is too enthusiastic to do this kind of stuff. So I mean, it strikes me that in any sort of permissible legal system, you could end up with a situation in which the law says that assisted dying, whether it be euthanasia or assisted suicide, is perfectly legal, and there is as few regulations as you can imagine, and yet it still never happens because no one is willing to be the doctor who presses the plunger, in which case, unless you think that there is a positive right to be assisted, then there's not much that you can do about it. Now in Canada, particularly in Ontario, there is a bankable right, if not to be assisted, then at least to be referred on to a medical practitioner who will assist. So there's much more leverage that the patient has under that system. But in the proposed UK legislation, then yeah, we could imagine a situation in which all the legal boxes have been ticked, and yet it just doesn't happen because there's no bankable right.
And which, eating in still further, looking for such people, that 6 to 8 weeks it takes may become 6 months trying to find.
I think they had that in Australia because they had really tight laws originally, and your qualifications to do it meant that virtually nobody, almost, if you had a really unusual condition, it was very, very hard to find someone, and they absolutely did time out. I think they then, the next lot of states had slightly more relaxed laws. But I think the British Medical Association have made it really clear they want a system outside of healthcare. So whether that's teams that can come into the hospitals or it's something more like the Swiss situation with Right to Die volunteers doing this. These are doctors who are volunteering. And I think for them, they often feel it's a real altruism in doing that. They're doing what the person wants. And I think as well, people imagine it might be your GP doing it. Well, it's unlikely. Apart from anything else, they won't have the time to sit with you whilst you go through the assisted death, which is the case in this law. But the people didn't really mind who did it. What they wanted was to get the assisted death. And because it was done with compassion in Switzerland, it didn't matter if it was a doctor you didn't know.
And it might also be that either formally or informally, people involved in assisted dying, doctors and nurses, may only be expected to do a handful a year. So the potential psychological damage of, we're not talking of teams that might be going in doing this job every day of their working lives.
Although in Canada, it's possibly getting a bit like that. I think because it's like of the 5,000 deaths, is it 60 or 80? I can't remember what it is, but it's done by very few people. Right.
So there is a danger of that. Yeah. And I assume they would also then need some sort of psychological support if this is likely to be a problem, like in some professions like counselling, where you have to have a counsellor to keep an eye on you, taking on board that stuff. Again, several questions here that I have, many of which have actually been answered as we've gone along here. Certainly, one that I would like to raise is again this issue that more general one really, but it's one that as I'm now moving into the age bracket myself, that struck me, the concern that the elderly themselves, who by their very nature may only have a few more years, may find themselves with illnesses that could prolong their life, being put under pressure by who? Family members, whatever, and of course, more chillingly, the idea that at some point down the line, governments desperate to save money upon long-term care may create changes in the regulations, if not the law, to allow this to be easier. And examples that struck me about. There's almost a culture in the media of using terms to describe the elderly, but actually quite derogatory, which if used about any other group, bed brockers, codgers, duffers, how privileged the elderly are, and so on. If they're not sitting in their big houses, what about the young? That they may, and how expensive they are, and how little they do. That the idea that they may well become a culture created inadvertently that encourages people to move towards that. Now the law may be changed. This leads on to a question that one of the people invited to see this program mentioned, that well, two things. One, how likely is the legislation in England and Wales to pass, and if so, when? I understand it's going to be going almost endless amendments at the present time. But do you personally think it is actually going to come into law? And if so, when? And having said that, once it is in law, and I'm going to raise this other question, what safeguards will be put in place so that this or future governments do not change the parameters around the criteria for assisted dying? You know, the slippery slope argument. I suppose under our legislation that could simply be changed by regulations or changes to the legislation, but perhaps people are looking for more safeguards than initially would be the case, and making this sound more complicated than it is. First, one, how likely is it to pass? And secondly, what sort of protections are there against the slippery slope argument?
You're the expert on the first one, Alex.
Well, gosh, I wouldn't go that far, but I think, I mean, my sense of it is that, so it's going to go to report stage and third reading, I think on the 25th of April. And looking at how people voted in the second reading back in November, I think it was something like 250 to 330 or thereabouts. You know, if 30 odd people change their minds and either, you know, against it, then it will fail. But, you know, there's a chance that some people who voted against it might now want to vote for it. I think it's more likely that more people who voted for it to give it chance at committee stage will now look at it and say, actually, no. So I think it's going to be really tight, but I think my view is it probably will squeak through. But then, you know, it could change again if it does progress onto the House of Lords. They'll have the opportunity to amend it. It might run out of time because opponents might want to kind of, you know, run down the clock. Although I understand, you know, from anecdotally that shouldn't happen. So yeah, who knows?
I'm a bit less. I'm a bit. I tend to think it's less likely to pass. And the reason for that is I think that there is. I think, as Alex says, it doesn't need that many people to change their minds to shift them. Although the majority was superficially fairly healthy on the second reading. But I think there is some degree of in which people allow it to pass a second reading to allow it to go to the committee. But my sense is also from sort of vibes I'm picking on social media, that there's a lot of MPs who are kind of really quite hacked off about how the committee stage has been handled. And they think that the committee has been loaded in one particular way, that there's been amendments kind of strong arm through, or amendments made from critics that have been equally rejected in a fairly perfunctory sort of way. So it may be that people who are sympathetic to the content of the law may end up vote against it out of pique, really, about the way it's being pursued, because there is this argument to say, well, look, you know, if it does pass in April, given that it was only introduced to the Commons in November, that's less than 6 months for what is morally astounding. If you think about the amount of time that's spent considering, you know, altering council tax or something like that, it gets months and months and months and months, and it can take a very, very long time. And yet we've got this kind of thing where it's a fundamental change to the nature of the right to life, or people's rights to assist in another person's dying, and 6 months all done, including a Christmas break. Dumph. And I think people there is a few MPs that with whom I'm in contact who've kind of gone, it's just too quick.
Yeah. And if you look at other private members' bills, say in the 60s, that brought about massive changes in the law in connection with divorce and abortion and homosexual law reform, they may have been private members' bills, I think all of them, but they were passed at the end of many, many years of reports and investigations from Wolfson to the homosexual law reform. And also, of course, they had the backing of the government that could then throw in resources to make sure this is properly constituted, polished, legislation. I understand with private members' bill, it's almost left up to the MP and a few friends to get the thing sorted, which isn't necessarily ideal when, as you say, you're dealing with something as enormously complex and important, even more, for me, even more so than I thought an hour ago, that it's been done so quickly.
And I think there is a delay, though, that now talking about, so Stephen Kinnock, the Minister for Palliative Care, initially there was going to be a 2 to 3 implementation period. It's now going to be 4 years. And they've actually said during the committee stage, because the government has concerns about some of the vagueness in the bill. And I think some of the vagueness is purposeful, so it could be shaped at the next stage. But also, it's obviously going to raise concerns for how do you implement this. And obviously, the Secretary of State for Health, Wes Streeting, is against passing it round now, because we know it's a very difficult time for the health service. And we've done much more minor things that have gone horribly wrong at the end of life, like the Liverpool Care Pathway, which didn't have much of an evidence base, but where the problems really came was the implementation, the practical elements, and we end up with the Daily Mail campaign against it, and the Daily Mail and the Times and the Telegraph are already coming down quite hard against the bill. So you do this wrong, this could go very, very wrong.
That's again. So that largely deals with those questions. I don't recall, and I may have missed it, that there are other elements as well. I came across one article, or part of an article, and the Ledbetter or Leadbeater bill doesn't seem to have it in it, as I understand it, the idea of the need for equity impact assessments in this, because I think it is in Canada where certain groups, particularly poor white males, seem to be polished off with their the assisted dying scheme more statistically than any other group, and that's another issue to see, because we know our law in practice can discriminate against certain groups, even of course these days that's never an intention. It can be an actual result of that, and that doesn't seem to be in this legislation at all.
Yeah, it speaks to your point earlier about a moment ago about safeguarding and can we avoid the elderly and the vulnerable being pressured into something that they wouldn't have taken on. Now, I think that there is a certain amount of, for my money, shroud waving about, the government is facing social care costs, and we could just push elderly people into the suicide chambers. And I think that is over-egged, but and also, one of the reasons why I think it's over-egged is because I think that simply because you're elderly or simply because you're disabled, it doesn't mean that you're utterly biddable. You can be just as mulish as a younger person or an able-bodied person. So there is, some of those concerns I think are overplayed, but that does not mean that they're utterly irrelevant. There was about 10-15 years ago, there's an interview that Baroness Warnock gave to the Church of Scotland magazine, in which she just kind of mooted almost as a passing thought that there might be such a thing as a right to, as a duty to die, and she's basically saying there comes a point where you possibly morally decent people would recognise that they're a burden on the people around them. And it was just a kind of parenthetical comment, and it was in the context of a discussion about other stuff, and the Daily Mail got hold of it. Baroness Warnock says duty to die.
Oh yes.
And you kind of get this idea that that there will be almost, a bloke outside your house with a stopwatch going, well, that's your 70 years and 10, mate, off we go. So there's a kind of caricature concern, which, and any bill, we have to make sure that there is not a slippery slope. I think it is avoidable, but it does have to be exactly clear what's going on, and that even if we think that there is a moral, that there are moral reasons for people to accept that they are being abused, it doesn't follow from that anyone else can make the point for them.
No.
So that's
I think it's what's interesting looking around the world is a few years ago in the Netherlands, which has got one of the most liberal approaches in the world, there was a campaign to expand eligibility to older people who passed the age of 70 and who were tired of life. And this was a really prominent campaign I guess it was around 2008, 2009, around that time. And in the Netherlands, what's really interesting is that the legal change was very much supported by the medical profession, because the way they frame their obligations is that if somebody is suffering terribly and they've tried other ways to help that person and that person wants to die, then there is this kind of professional medical obligation to provide euthanasia. But they didn't want to go, and step over into this sort of even more inclusive approach of allowing people just based on their age and the fact that they were a bit tired and fed up to access it. So I guess that's encouraging in that, given that the Netherlands have literally it's arguable about whether they've expanded it or whether actually the place that they're at now in terms of allowing people to have it after a time when they don't have mental capacity, because you can have an advanced decision to request euthanasia when you have dementia, for example. And obviously expanding it to include people with mental health illnesses and expanding it in terms of children. People would argue in support of what's happened in the Netherlands, well, actually, they haven't really expanded it. It's just that the way the sort of due care criteria is interpreted, this was never explicitly prohibited. It's just that we weren't quite sure. However, they were sure that they didn't want to expand it to include older people who are tired of life. So and that was an interesting one, that if they haven't gone there, I'd be very, very surprised if a much more restrictive approach ever went that far.
Yeah, I mean, the Netherlands is an interesting case because there's two things to say about that. In the first place, obviously, a lot of people, I think, think that euthanasia has been legal in the Netherlands for decades and decades and decades, and of course it hasn't. It was tolerated by the law for a long time, and then in 2002, the law was essentially a matter of formalising what had already happened, and this speaks to doctors treating as being part of the medical role. So again, there's a sort of moral claim rather than necessarily a legal claim, and the law caught up with it. But the flip side of that is that there is also in the Netherlands, and this speaks to the flip side of the vulnerable elderly people point as well, there is something called the Groningen Protocol, which deals with what amounts to non-voluntary euthanasia for children. And the rationale there is simply if a child is suffering, a neonate is suffering terribly or is expected to live a nasty and short life, then it falls within the medical remit to save them from this burdensome life, and therefore there is non-voluntary euthanasia for children. And again, the Dutch law does not permit that, except that it kind of does. So if we're talking about vulnerability, a lot of the attention in the UK has been on the elderly, but exactly the same kinds of reasons could be brought to the table in respect to the very young. And there's the sound of me, and the sound you can hear in the background is me opening an enormous can of worms, and they're slithering all over the table as we speak.
I think even with dementia, that's a can of worms as well. So although you can have, it's gone through the courts now, you can have an advance directive. What it comes down to is the doctor now is making the decision that your life is unbearable, and at what point that happens. They had the trial case where they had they wanted to test the law, so they gave someone some sedation within their coffee, but unfortunately they woke up and they were held down and euthanized, and this went through the courts, and the decision was the doctor can decide when someone's life is unbearable. Now that is a massive change in where we have come from, and of course doctors have opted out of that, so very few doctors will take that decision. So there's a few people who are willing to follow someone through and make that decision, but again it comes down to, we might feel as a society we want something, is it practically possible, and are you going to find people to do it? Except
Of course, often doctors make decisions about whether a life is worth living anyway. So if you're wheeled into A&E having been in a road accident, and the doctors might very well decide we are not even going to begin treatment with this because it would be burdensome. So already doctors are making decisions about lives worth living on behalf of other people. So yeah, intuitively there's something different about the assisted dying sort of context. And I think there is an important moral difference between a doctor deciding not to start what they hold to be a burdensome treatment, even if it preserves life for a critical time. But yeah, there's something weird about the ways that we culturally accept doctors making that sort of decision on a Tuesday and then on a Wednesday.
But there's a difference between withdrawal and actively injecting the drug. I think that's for the doctor. That's where they see the difference.
Yeah, I think that would probably have to be what it is. But again, this prediction about lives worth living, they are making that decision on behalf of someone else, and that's again, I think often the decision about this permissibility of assisted dying, it's got actually much less to do with the patient than intuitively we might think. A lot of it has to do with the doctor and what they're willing to do and what they think is permitted
And what they know.
and what they know. Yeah.
And the idea, I just struck with the idea of the tide of life bit. You know, it always has this image of some older person being fed up, but quite often opinion polls show that the older age group are amongst the happiest of the generations. How many teenagers do we know are fed up with life, and then grow out of it? I mean, I don't know how you would calculate, how that would be acceptable to help that person end their life when they're in what may be simply a temporary depression in their life.
Yeah, and there's concerns about sometimes known as the Werther phenomenon. So this was apparently when Goethe published his novel *The Sorrows of Young Werther*. There was a kind of spate of fashionable suicides because they were also this kind of romantic hero, and it's what you do. But yeah, so people can be pressured to, especially young people can be very young people, he said it in a patronising kind of way, but they can be very impressionable and do really, really strange things.
Yeah, and indeed, so-called rational adults can do very strange things. And interestingly as well, that's something that very temporary. Years ago, I came across an article which argued that suicide rise in the UK following Conservative election victories at the rate, and then falls when Labour wins. Only temporarily, then it gets back to the sort of norm there. So it's quite interesting, and that's another thing to hear that we're looking at here. So I assume this legislation, if it got through, wouldn't remove from people the right to go to Switzerland and Dignitas. That would still be an option.
And we know that people still do that from countries where it has been legitimised, and that's a really interesting question, why they are doing that.
Yeah, and of course, given we're coming to the end of the time here, but one thing that I came across, that the large numbers of people, several hundred a year, ending their lives because of ill health, terminally ill health, is such legislation really necessary? Given that those who really feel the need to go and leave this life because of a terminal illness or something like that, will find a way to do that, and are doing already, irrespective of what the law says, and will find friends, family members willing to help them, and then take the consequences.
I think one of the things in some Belgian research, where they were interviewing people with mental health conditions about why they were trying to access an assisted death, and these were people who had repeatedly tried to kill themselves, they said one of the big elements for them was, A, it would work. They knew 100% it would work, so there wouldn't be any long-term problems of being in ICU and all the rest of it. But also, it was much more acceptable because it was a doctor doing something. It was a medical act. It wasn't suicide. And it made it much more acceptable for the family, for the bereavement, and everybody after. And I think really this is what a lot of this is about.
Yeah, and that's not a world away in some ways from the doctor going to the next of kin and asking their permission to switch off a life support machine. They've made a judgment that person is never going to recover. They just need legally to ask somebody, can I switch off this machine? And I suppose in certain circumstances, they can switch it off anyway, without anybody's agreement. Yeah. So it's going to get a very interesting and complicated topic. Right, we've got probably one. We've already passed the time on my watch. Are there any final comments you might want to make before we complete today? I think almost everything has been said.
It's all been
that
said.
Needs to be said. I think many of us need to go away now and digest what all of you said. So I'd just like to join everybody else who's been involved in this in thanking you three for your contributions today. And I found it personally fascinating and has made me want to find out more about this issue, irrespective of what happens to this piece of legislation. And certainly I'll be following it more in the future in the newspapers than I have done in the past. So once again, thank you very much, and thank you all for being involved in this today and watching it, and hopefully any future events you'll be involved in that as well. So bye for now, and enjoy the rest of the day.